Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to explore the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Professor Dr. Prafulla Kerkar sir. Sir is Emeritus Professor at said GS Medical College and KM Hospital, Mumbai, and consultant interventional cardiologist at Asian Heart Institute, Mumbai. He is former guideline committee chairman of CSI and CSI guidance committee guidance document on acute MI and HF care during COVID. Sir is chairman of board of studies for Maharashtra University of Health Sciences, former chairman of Pinnacle India Registry in collaboration with ACC, former president of CSI Mumbai chapter and organizer for CSI Con 2018. Sir has participated as investigator in landmark clinical trials like CREATE, PREDICT, TAO, Paradigm HF, Paradise MI, SELECT, SCORED, Impact MI study, ZS studies, and Surpass CVOT. He is national leader for Paradise MI and Surmount MMO trials. Sir has several hundred publications and presentations in national and international journals and meetings, including prestigious orations and awards to his credit. Thank you, sir, for accepting our request to be the course director, to being the course director and guiding us to run this program successfully. Our distinguished moderators, Dr. Jabir Abdullah Kutti sir and Dr. Rajnikant Shastri sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. We have Dr. Jabir Abdullah Kutti sir, Senior Consultant Cardiologist and Director of Clinical Research Cardiology at Lisi Hospital, Cochin, Member Secretary of Institutional Review Board, Lisi Hospital, Cochin, Vice President of Kerala Medical Association, 1986-1987, Secretary Cardiological Society of India, Kerala Chapter, 2008 to 2012, National Executive Committee Member of Cardiology Society of India, Honorary Secretary, Society for Heart Failure and Transplantation, Organizing Secretary for Annual Conference 2020, Society for Cardiac Imaging and Physiology, Secretary for Cardiovascular Research Society, faculty at various national and international conferences, investigator for multiple clinical trials, Engage AF, TIMI 48, Examine, Atlas TIMI 51, CANTOS, ODC, Paradise, MI, and Kerala Acute Heart Failure Registry, etc. He has various publications and textbook chapters to his credit. He is editorial board member for Indian Heart Journal. So Dr. Jabir sir will be joining in some time. Let me honor to introduce the second moderator for today, Dr. Rajnikant Shastri sir. Sir is Senior Consultant, Preventive and Non-Invasive Cardiology, Medanta, the Medicity, Gurgaon, Haryana. He is experienced cardiologist with over 2 decades of diverse clinical experience, specializing in preventive and non-invasive cardiology. He has proven expertise in patient care, emergency medicine, and advanced cardiac diagnostics with a strong background in academic and clinical cardiology. His key interests are non-invasive cardiology, preventive cardiology, cardiac imaging and diagnostics, and critical care, patient education and counseling. Thank you, sir, for joining today. I would have privilege to introduce the speaker for today. We have Dr. Pranav Shamraj, sir, Consultant Cardiologist and Director Cath Lab at BKL Walavalkar Medical College and Hospital at Chiplun, Ratnagiri, Maharashtra. He is associated with BKL Walavalkar Medical College and Hospital, this institute, for last 8 years. He is well experienced in handling coronary and complex coronary cases, and till date he has completed 6,000 angioplasties. The case which he will be presenting today is how to manage the thrombus during STEMI PCI. As per the schedule, there was second case which was supposed to be presented by Dr. Pankaj Sarkar, but due to some emergency, he couldn't join today's meeting. Let me brief you all. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with opening remarks and context setting by our course director, Professor Prafulla Kerkar sir. It will be followed by case presentation by Dr. Pranav Shamraj on how to manage thrombus during STEMI PCI. 10 minutes case presentation, followed by there will be discussion around the case where the course director and moderators will participate. Following that, Dr. Praful Kherkar sir will share some interesting piece of information, and then we'll have concluding remark by the course director, and then I'll go for vote of thanks. I request audience to put their questions in comment box so that after the case presentations, we'll take up those questions for the discussion. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request our respected course director, Professor Prafulla Kherkar sir, to share his opening remarks on today's topic and set the context. Over to you, sir.
Well, thank you, Dr. Shivali, for those kind introductions. And we're all set now. No thrombosis, KNOW. Knowledge of thrombosis is so apt a title. And we started initially these kind of webinars to look at thrombosis and ideal therapies to have no thrombosis. But subsequently, this program has evolved to interventional cardiology, and wherein, as compared to the previous times when we have had calcium modification or bifurcation, left main disease, etc., today we have today we have something to deal with thrombus during PCI, and it is so apt a winning title, I think, also of this. So the KT live session or no thrombosis live sessions is about interventional cardiology cases, and Dr. Pranav today is going to show us something that he has to encounter management of thrombus during a STEMI scenario. Having said that, we all know as interventional cardiologists that a thrombus is, so to say, the villain of the piece when it comes to STEMI intervention. And I recollect I had spoken on a topic wherein how do you deal with the pharmacological agents in the cath lab, and then I tried to speak some 10 years ago, and then I happened to have read a colleague cardiologist from Mumbai who had written an editorial. Dharam Kumbhani today writes for acc.org also, and he is a one very good writer for that matter and a very good interventional cardiologist. So Dharam had then wrote about trying to look for effective treatment, pharmacological treatment, of course, for managing this villain in the cath lab. Pharmacological treatment when you get the so-called no flow due to microvascular obstruction. And he said finding treatments he had likened it to treading on a road of perdition. Perdition means failure. Yeah, that's deemed to follow a path of failure. This was 10 years ago, a path of failure in terms of looking at pharmacological agents. And today also, we use a whole lot of pharmacological agents when we get the no reflow phenomenon whilst dealing with thrombus in the cath lab or thrombus within the coronary arteries. And I don't think things are any different 10 years down the line. There are a whole lot of agents which we could discuss afterwards. This is the pharmacological part. Now coming to the you want no thrombosis. You want to prevent all these no reflow. And towards that end, if we have to, what have we been doing up until now? We've been aspirating the thrombus out there, either deep intubating the guide catheters, good old days during the days of POBA for PCI related to MI, or we have had aspiration catheters. Now these aspiration catheters, by and large, I suppose all of us use manual aspiration. There have been also mechanical aspiration where there is a continuous suction applied. Penumbra is something that my neurointerventionists use also. But all this, if you go to look at the guidelines, they talk that they cause more harm than good, right? It's a class 3 indication. And yet, how do we deal with it? Well, it all depends again on the main aim of STEMI intervention is what? You want a TIMI-3 flow down the artery. You want to avoid distal embolization, and all this using all the kinds of pharmacological agents. And we obviously use in a STEMI scenario both anticoagulants as well as antiplatelets, dual antiplatelets. We want to minimize bleeding as well. So when you tread that rope, it becomes quite difficult. The path to perdition is there. And let's see what kind of a perdition occurred with the failure or success, we always try to show success stories. But failure, what happens? Failure prognostically, if you fail to achieve a TIMI-3 flow, or if you get that no reflow phenomenon, these people are destined to have large infarcts, poor adverse reverse remodeling of the LV, and which affects the mortality both in the short term and the long term. So that is the bad thing about it. Forget the fact that we cannot come out and show cosmetically good angioplasty done to our patients at that point, but it is augurs not too well. So with that little opening remarks, let's see what we can do. What is the current state of knowledge? Our moderators, Dr. Shastri and Dr. Jabir, if he joins us, will also throw light upon it. And I would, without much ado, give it over to our young dynamic cardiologist who is from my state, who's from not too far away, Chiplun, which is fairly close to Mumbai, and it's a lovely town that is. And over to you, Pranav. Let's see what you have to show to us.
Thank you, sir. Good evening, respected faculty members, and I thank Emcure for giving me this opportunity to present my case. So, as we had discussed, to keep the presentation to a 15 minutes specific time, so I created two cases, and in particular, the common entities I see in our area. I have made two cases to discuss on how to manage thrombus. So it is, as we say, managing thrombus. If we expand this, that managing thrombus, and in regard to the thrombus, the no flow, the slow flow, the no reflow. That is what is the overall concept when we are aiming at managing the thrombus. When we see at the patients who are very young, a 25-year, a 30-year, or a young patient, a heavy thinker, or somebody with a thrombophilic disorder, and when they come with acute STEMIs, they are mostly because of plaque rupture and they have massive thrombus. Most of these cases, as already we have seen in the newspaper, in metro cities are managed by laser. And most of the centers intracoronary thrombolysis or thrombus aspiration if they are in the time range. But in particular scenarios like our setup, patients come even beyond the 24 hours and they are in a hemodynamically unstable condition, and which is very common because of delayed presentation. So as sir has already highlighted, we have two standard ways. When initially was thought on pharmacological approach, that was the standard of care, and the mechanical interventions where the manual thrombus aspiration is the cornerstone of the therapy. Also, the thrombustor can be used to deliver drug distilled and help in improving the slow flow, no flow. Certain techniques like direct stenting, deferred stenting, and if after stenting there is slow flow, then handling the slow flow. People have used microcatheters, thrombusters, direct through the guiding. Also, they have mention of cut balloon to deliver. And if we have seen the centers who are more based on imaging, they have a role of imaging to optimize their results. At times, they defer the stent, they come out if they don't see deflection. People have also discussed about the coated balloon in most of the scenarios. But here, I want to present two cases where how like as the case went and couldn't establish the flow and how the algorithm, how what to do in each case. I just focused on how dilating the lesion helped me in achieving the flow. Now, this is a young male who stays next to our hospital, almost 2 kilometers
Sir,
away.
your screen is not
Can you
visible.
share your presentation, please? Yeah,
Please share.
can you share screen so that we can see what yours?
Sorry.
Yeah, now we can see.
Now, we can
You
see.
can
Go on
make
a
it full
slideshow.
Extremely sorry.
Yeah.
So as I discussed, so as sir, as you have highlighted, so the major points, and here I would like to focus on the case where so this is first case where this 50-year male, he's a diabetic, and his HbA1c is around 9, not poorly controlled diabetes. Now he presented at an interval of 24 hours to a general practitioner. He presented with upper GI symptoms. So he had burning sensation and he was very stable. So the doctor himself brought him to our hospital because he was very close by, because he was astonished to see an acute inferior STEMI. The patient had come walking to him. And in the same similar fashion, he got hospitalized. This was his ECG. This is a case done recently itself. So ECG was showing persistent ST elevation. There were reciprocal changes, lead 1 ABL, and also V2 to almost V5. There were ST depression. Sir, I just could not upload the angio in the presentation because it was not accepting. Share the So this was an angiogram, which the left system was showing some plaque in the left main, and the RCA was completely occluded. And sorry for this. So the left main had shown some eccentric plaque at the origin. So it was mainly with the RCA, which was 100% occluded. The patient was very stable when we started the procedure. So this was so with the intent of opening the artery, I thought of proceeding with the case. So the RCA was occluded from the origin, and I just took a JR guide and a regular wire that was run through, and I thought of going, but there was resistance at the site where just after the short segment of the proximal arc. So I thought of going with the balloon support. I took a 2O balloon, and then with the support, I thought of maybe I could get through that thrombus, but the wire was going either in the branch or I could not go distal. And also the guide was not giving a good support. So with this, I thought generally if it is acute thrombus, even the run through wire goes through. So I thought I've shifted to a better guide support. So took a AL1 guide and switched to a fielder FT wire, and with the balloon support, so I was able to go across through the lesion into the distal RCA. And after crossing, I could see that the whole of the RCA, I mean, at least there is a thrombus proximal to the mid arc. So as it was already more than 24 hours, and so I thought of going with a low. Initially, I did the balloon daughtering, and then that was the flow after balloon daughtering, what we are seeing. And then just thought of going a low profile, low pressure dilatation to just have an idea of how is the RCA. And then after this injection, the RCA is seen as there is thrombus right from the origin in the mid RCA, and actually even the distal RCA is showing thrombus, and I could not see the PD and PLV after. So till this point, things were okay, but after this, the patient started crashing. So his ST elevations went up, and his ST elevations went up, sir, and patient went into VT and VF. So by the time we could resuscitate him, the guide had also like it was not aligned, and eventually the whole system came out. So I gave CPR, stabilized him, started on inotrope, and with all this again reintubated the RCA, and then with the anesthetics on board and all, the patient was fully sedated. So again, we had to restart now. I had to restart. The RCA was again back to the original state, but this time the patient was not in a very stable state. So again took a JR guide because this was a emergency and dire state, and luckily the guide had gone in a better position. So tried to cross it, the wire went easily, and then the sequential dilatation I did with a 2O balloon. So from the distal, initially the dilatation proximal had given us the idea. So distally to proximal I dilated, and this is now the vessel seen after pre-dilatation. So always we have this dilemma in thrombus, go ahead with stenting and avoid the dilatation. But like this scenario, actually I was not able to identify where exactly to proceed because the whole RCA was full of thrombus. And in such scenario, I would always leave it if I can get a flow, and if the patient remains stable, to take him again after some time and then reassess. So always there is a dilemma. So after this dilatation, I could at least understand that the proximal RCA is where the culprit lesion is there, and thought of stenting it with a 3 into 36 millimeter stent. So that was sirolimus eluting stent, and the stent was deployed at 12 atmospheric pressure. And after stenting, I got a better flow in the RCA. Beyond the stent, there was still residual lesion, and the distal RCA over here is clearly showing thrombus just before the origin of PDA and PLV. There is a lot of spasm. The patient is on high dose inotrope. But after the flow was established, the patient was stable. So with this in mind, I thought of putting another stent to the mid RCA segment. And then more important, which I could not show it here, is gave him lot of intracoronary injections. So most of them were adrenaline and nicorandil, tirofiban in sequential doses, multiple doses, and finally could achieve this kind of a flow. There is in this scenario, I did not. I just pore dilated the overlapping segment of the two stent, and the proximal stent was little under expansion. But considering the hemodynamic situation, I did not pore dilate. And the distal thrombus, so put the patient on IV tirofiban and LMWH for 5 days. So as the patient I mean, over the sequential days, ECG improved and he clinically improved. The echo also showed improvement in the RV function. So eventually the patient was discharged. So this case is done just last month in August. The patient is following well. So sir, should I go to the next case or will just?
We'll have some discussion over
Yes,
this
sir.
case.
Yes, because other presenter is also.
Yeah, surely you can present the next case afterwards. Now, I presume there he is presented 24 hours later, or maybe Dr. Shastri, you might want to come in first and then we will talk.
No, you
Dr.
can go ahead,
Shastri,
sir. I mean, this is
yeah,
interesting.
okay. Yeah, so it's interesting scenario, and as what you very rightly at the start of the case itself you pointed out, that being in your kind of a circumstance over there, and generally, thankfully, Chipolun patients are not coming 24 hours later to KEM hospital in Mumbai, where I'm the former head there. I'm an emeritus professor there. So that is what typically patients from Chipolun would land up coming overnight and things like that. And by the time they come to us, it's so late. And it's unfortunate that though he's a resident of Chipolun itself, he came to you so late. Now, 24 hours later, for the benefit of the audience and for everybody, could you have, meaning unless it was ongoing pain going on, the reason to intervene was the persistent ST elevation. Is that right? Or did he
Yes,
have
sir.
pain? Did he
He
have
was
pain?
not, sir. He never presented with pain. He presented with upper GI symptoms. So, and he was diabetic patient. So,
Okay. So
and
now 24
he had
hours
an unstable
later,
ECG.
yeah. What was the reason to intervene? Otherwise,
Wait for
reperfusion
24 hours.
24 hours later is generally a class 3. Now, we don't want to
Yes.
do it unless there's hemodynamic instability or
Instability
there
is
is pain. So I suppose there was pain there. Persistent ST elevation could also mean that the distal bed is all choked up and therefore there is nothing moving. Did you have a chance to look at the echo before intervening?
Yes, sir. I had seen the echo. So the inferior wall was akinetic and the RV free wall was also not moving. So patient
I
is
see.
perhaps TR. And because he did not present with the classical, basically he presented in the morning with GI disturbance burning. So in this case, like a very asymptomatic patient, as we already read as per the cardiology knowledge, that we do not intervene. Now this was kind of a
Wait.
patient who was in a borderline zone, and he had presented with symptoms in the morning, and by the time come to our hospital. So It was
So
just
he
at
was
the exact
recently
position.
aggravated symptoms,
Yes,
so reason
yes,
for though his symptomatology, it's always very difficult to really point history wise, make out the time of occlusion of the artery. It is sometimes there is something like a pre-infarction angina going up. So at that point in time, we teach our students history taking wise, you should want to know the worst pain or the worst symptomatology that was there. And that was just recently in the morning. So therefore it is kind of an acute or stuttering infarct kind of a thing, right? So therefore there is a reason to intervene. Now, he did develop. What do you think happened for you to get him to suddenly go bad and get that no reflow kind of a situation? Is what I'm asking.
maybe he
The
was
whole
having
idea
some.
is that you can't go
He
ahead.
was having some collateral flow, and once I did the integrated wiring and the balloon daughtering, and so the whole hemodynamic, the whatever existing supply was disturbed.
Blocked.
Yeah, correct. So now the thing is that it is also possible now that he was collateralized from the left, is what you think, and maybe the collaterals got blocked in the process of all this. Is that what it is? That is
Yes,
also
yes,
one possibility. However, the thing is that with that Amplard's guide, I only wonder whether the Amplard's guide jammed in further, and that is one more reason why you could get VF, VT, and all that. And you did come in with a non-Amplard's guide. You came with a right coronary again. And the thing is that, yes, in a acute scenario, you tend to get more support, but that support was not so much an issue as the huge thrombus load there that was making you unable to cross it at the beginning. But then the crossing helped, possibly because of a better support is one way of it, or a better wiring could be the other way that you were able to do it. Now, did you, since it was acute on chronic, acute stuttering MI kind of a thing, and the recent thing was it was supposed to have occluded just a few hours before, possibly with the ST elevations also. Had you had a thrombuster with you, would
yes,
you have
yes,
thought
yes,
about
sir.
doing a,
Yeah, yeah, sir. I mean, I regularly use a thrombuster, but in most of these cases, aspiration what we get is less than 10%. Mean, the real
yes,
thrombus, the kind of fresh thrombus, the way we look on angio, the bubble kind of, or the bobbing thrombus or the floating. So in those cases, we have got good results, but in all these scenarios, the thrombus aspiration has not added because I had kept other cases of thrombus aspiration. I thought the other presenter might present, so I had focused this case on a
I know, I
balloon
know.
based
So
method.
here is one, I'm just trying to point out to the audience as well as to you that here is a case where, yes, the point is that the symptomatology was more than 24 hours, but the worst symptoms were recent. There is still a scope to put in and the thrombus burden is large. Though otherwise it's a class 3 indication to use today, a thrombus aspiration basis a large body of data. You have all the T's, the
Taste
three
total.
T's, the trials that
Taste
we talk
total.
about. TAPAS, which was a single center trial, then the TASTE trial, and then the total trial, total being the largest of them all. And a totality of all these trials taken together, you don't really do good in terms of, meaning you might cosmetically get a good thrombus suction and all, but it does not, I mean, you might even achieve a TIMI3 flow. But having said that, I was alluding to penumbra, and there are very short, meaning studies of penumbra. There's a cheetah trial which talks about, and I'm talking about penumbra because my neurointerventionists use it a lot in the stroke scenario. So they're therein to suck it out is with a continuous suction. It's quite possible to use a penumbra, horribly expensive as compared to our good old manual aspiration thing. And that could give you a better TIMI3 flows and without strokes. Having said that, again, in these young patients also, as well as in the elderly, the thrombus that you land up aspirating, it is imperative to, yeah, even when you are engaging the guides, the right coronary was flipping out even with an injection also. So a good engagement of the ostium of the coronary and during the sucking, when we suck, is important, because otherwise a little bit of a thrombus, if it escapes out of the osteum,
Goes to the
you
brain.
might get you might get strokes. And strokes are actually in some 10,000 plus patients, such kind of trials. The stroke rate is higher when you compare it with not having used a thrombustor. So that is what we must keep in mind. And of course, your case qualifies. You did not use use it is one thing, but this is a case that definitely qualifies for a thrombus aspiration because of the huge burden, and you can see the burden of the thrombus within the entire entire right coronary. Having said that, again, the advantage of a right coronary over an Amplatz here is sometimes you can aspirate more just with a guiding catheter. You can just take a catheter down there, a balloon catheter down there, and you can slowly clockwise rotate and you can deep intubate this because it is not a shepherd's crook RCA really. You understand what I'm trying to say? And it sometimes what works is putting deep intubating the guide catheter and using the guide catheter and using the guide catheter to actually suck out the thrombus. So having said that, I would like Dr. Shastri to throw some more light from on this case. And you have any other viewpoint about this?
So in this case, did you think of doing intracoronary fibrinolysis?
No, no, sir. Because I believe that this is kind of a more formed thrombus. So if I would have thrombolized it, then I would have like it is a deferred strategy, more of a deferred strategy. And this was so diffusely diseased that I mean, if and already the patient had a hemodynamic collapse, so I was not having that much time that somehow I wanted a good flow so that he survived.
Yes, good.
So excellent demonstration. And again, not to chase, the only issue was you did land up putting in a second stent down there. So more the material, more the stent here, greater amount of metal here, the more the thrombotic chances of reocclusion, isn't it? Meaning also, of course, now I would go thinking aloud. If you had access to imaging, would you have imaged here?
Yes,
Post
definitely.
stenting, especially post stenting.
Even sir, before stenting, I would have imaged to understand the whole scenario and then kind of avoid the metal as much as possible.
Before stenting, your ability to take a wire there was such an issue. I don't know whether an IVUS catheter putting it
if we had got a better lumen and a better a good result and good flow, and if the patient would have like given a chance, like not in scenario, but most of the cases I would, if I have a imaging, I am a person like I would go for a imaging because it gives add lot of value. And the second case actually I want to present is in that regard.
Okay. So then let's go ahead and let's talk about the second case. Let's look at your second case now.
Sir, this is a 75-year-old female, and she presented with inferior wall MI, and patient had angina at the time of presentation, and the angiography showed RCA was 100%. So, sir, somehow my presentation is not allowing the angio to get copied in the PPT, but the plastic, so I couldn't load that angio. So she had a RCA 100% and LAD was showing a 90% occlusion. And the RCA is totally occluded. So with this, I thought of wiring the RCA, and it is a similar scenario. And if you can closely see that as the wire goes down, the guide is backing out. And this is the flow after balloon daughtering from the RCA. This is patient with
what wire are you using, if I may interrupt?
Sir, run through wire or BMW wire commonly.
Okay. Commonly use that. Sometimes, paradoxically, a very floppy, simple wire works more than a support wire. The way the guide catheters are flipping out, a support wire tends to flip out guide catheters, whereas just being able to do it with a floppy wire, things work better in a thrombus scenario also, that's what I was trying to say. Yeah, go ahead.
So after balloon daughtering, the RCA was, there was a TME1 flow in the RCA. Looks like a lot of spasm also. So gave intracoronary vasodilators and the did pre-dilatation with a 2O balloon in the proximal to mid segment. And this was the flow across the RCA. There is a grade 3 thrombus in the proximal RCA with some dissection. And then beyond the mid RCA, there is no flow. So I thought of going low pressure 2 mm balloon at 2 to 4 atmospheric pressure. And after the sequential dilatation, I could establish a TME2 or a TME3 flow into the RCA. And we can see that the proximal RCA as the culprit lesion, the dissection and thrombus. So with this, I decided to send the proximal RCA. So this was again 3O into 36 mm sirolimus eluting stent and deployed at 12 atmospheric pressure, 12 to 14 atmospheric pressure. And this is the flow. So patient had low flow after stenting. And I gave a lot of intracoronary vasodilators, multiple doses, but still the flow was absolutely not in. So in such scenario, normally what I do is take in thrombuster. I mean, because I just wanted to present a balloon-based strategy, my always initial choice is a thrombuster. But I would go with a thing where I could take a distal shoot, like a micro catheter, or if the thrombuster allows, and then see. But here, I just took a low-profile balloon, and while the initial dilatation, when I passed the balloon distally, I was getting a grating sensation. So I thought of doing some dilatation in the distal lesion. So in the first slide, we can see the balloon has expanded, but the third shot shows that at even going higher pressure, the balloon is not getting dilated at this point, and I'm feeling grating sensation on the balloon. So this. So again, I want to highlight that the first guide engagement, even the guide had backed out when the wire had touched this point, and at this point the balloon is not expanding, and even the tactile feel is also showing that there is a very tough lesion in the distal arch. So this is after the dilatation with the 2O balloon. So the distal arch is a whole disease segment. This is the iliocranial view where we can see the distal RCA disease right till the origin of the PDA. So here I would have always been happy to use the imaging and try to understand the scenario.
Yes.
But it is not available currently with us on a 24-hour way. So I again did a dilatation with a bigger balloon, a 2.5 balloon, and then took a 2.75 into 36 millimeter stent across that whole segment into the distal RCA, and then deployed it at 12 atmospheric pressure. So this is the initial result after deploying the stent, and then started the high pressure pore dilatation because this patient was very much stable during. So pore dilated with a 2.75 balloon in the distal RCA with a 3O balloon in the proximal RCA. And this is the result after the stenting and pore dilatation. So I am seeing that in the distal stent, after a few 5-6 mm, there is a haziness in it. So I thought either this is a thrombus or still it could be something apart from the thrombus, most commonly. And then imaging was not available. So I took a high resolution image, also took the stent boost. So this is a magnified image where we can see that the distal stent is showing some haziness. So I thought of going ahead and dilating with a high pressure, like almost 24 atmosphere into 26 atmosphere with the 2.75 inch balloon because the vessel was 2.75. So went there, and on the right side, if you see exactly at that point, the balloon really does not. So did that dilatation multiple times. Then I even had that grating sensation, and then with there was optimization of the proximal stent, and with this much amount, I accepted the result and stopped here. But what I inferred from my own understanding that this was either a calcified nodule or a heavy chunk of calcium, which could not be understood during the PCI. And initially, I thought it was a thrombus, but with all the steps, it was shown that this is not a thrombus. So, what I want to what I understood and I want to express is that sometimes a distal lesion, and in many cases we have seen that a distal lesion, if there is a critical lesion in the distal RCA or the distal bed, we often get no flow or slow flow, and that distal lesion often is, if it is not red, and if we just go with some vasodilators and multiple other strategies, we are not able to achieve a TMI. So keeping that thing in mind, that at times when we are not able to achieve good flow despite adequate strategies of the stenting, there could be a possibility of a critical lesion in the distal bed. So, with this,
Could you please go back to the film where you got a flow down that artery?
yes,
Right at the beginning, after having wiring and the first initial dilatation, and after the stenting, that is, yeah, after the first stent. So there was a suggestion there. Yeah, here it is. Now this one, this particular film also, you can see that that particular area where you're
yes,
getting a grating now. So,
yes,
and the previous one, if you show us again, previous to this, the previous, yeah. Now this one, if you show, can you play the film of that? Yeah, that one. No, the next or previous, where you
previous,
first got a flow down that artery.
yes.
Yeah, this
It
after
was the
having
stent
stented, then
after
after
the
the
stent.
stent, after the stenting. Yeah, see, after the stenting,
Yeah.
there is everything flowing slowly. This is the particular shot that I'm talking about. Yeah. So my only contention is that great job. You have done a fantastic work, meaning in terms of what you have done. My only thing is that intervening segment na, immediately post the stent, and where your distal stent has started, you left an intervening portion, right? Or
Yes, sir. I left the portion because I did not want
because
to do a metal.
eventually,
Yes,
I know, I do agree with you. You took a fairly long stent distally also. So I'm thinking that intervening portion that you have left at the end of it all, that I on this basis here, this shot, if you see, you would might want to think that there is some distal dissection at that point where the proximal stent is done with. Okay. But like you said, and even the first shot, the other one that I showed you, there was already a lesion at that site where the grating was. Correct? There was
yes,
a
sir.
lesion there. This was my worry when you first showed this, no? That how
Yes,
do you decide here whether that distal edge of the stent is not dissected and therefore the slow flow versus how? So you have to build up. It is all your gut feeling at the end of it all that decides what is it. So this particular shot that is there, no, where you can see a post stenting, the first shot that you're
yes, sir.
seeing,
Yes, sir.
that the flow is the stented segment is good, and after that suddenly there is nothing seen, no. So I'm just wondering, you
Yes,
must have obviously dilated the
yes,
distal end of the
yes,
stent and further down, but it
yes,
is disease there also, and then you have left a portion in between. That's about all. But
yes,
it's not obviously a dissected portion, so you're
yes.
fine there.
Yeah, sir.
Yeah.
Actually, when I handled the distal segment, I had also the plan of like to take care of this
Yeah, yes.
because
I'm
that is also.
wondering now you have already
So, yeah,
jacketed the artery.
yes, sir.
So why
So,
leave that
Why leave
segment,
that
disease
alone?
segment
so,
in
sir, I
between
left
the
it
two?
because this patient also has a LED, which I will address at like a interval, do the check shoot of this, and also see the LED that time,
Yeah, yeah. So that
and
time you must
go
do the
and
check
go ahead
shoot.
with
So
a
what
Monitor
better
was
this.
preparation with imaging and stuff. So that
I
so have
was
you done the LED or what is it?
no, sir, not done. This is done just 15 days back. So
Okay, okay, okay. Dr. Shastri, can you just throw more light on this case, please?
uh If you look at it, sir, basically, I think IVUS would have made a huge difference before he started off itself. He would have had imaging. Possibly, he could
Yeah,
have easily found out what was going on. So I think here was where IVUS was very important. The rest, of
exactly.
course, all in all, it is an excellent job done. His the at the point of time when he took that decision, that itself was very, very astute. So I think
Yes,
overall and all, a very good job done.
yes, yes, absolutely. And like my concerns about that intervening portion in the last shot, if at all the stented segment itself, if at all has got some little bit residual, but that is not the point. And what the point Dr. Pranav makes is that a distal lesion might come in the way of a Timothy flow rarely,
Yes.
and this is
Yes.
what this case amply shows. Uh, and the thing is, when you are dealing with a 75-year-old, that is when all this happens. Now,
Hmm.
in terms of, let us just discuss amongst the three of us because Dr. Jabir hasn't yet come. Now, what is the take in terms of use of a thrombustor to the point of stenting? I was, if it time permits, I was just, it is not my case really. My colleague has done this, but I was just trying to, if at all you give me a time, I could just quick, is there time enough or we can just discuss? It's not necessary. We already seen two cases. That's what was the objective. Or otherwise, I could quickly show you.
If you could,
Just
sir,
this is
that
about
would be
20
good.
few angles. Yeah, yeah, we could just look at this. Yeah. Oh, sorry, I have to first share the screen, right? Give me the chance to share it. Yeah, I will share and let me share the 1 second. I have to first put that thing up there, right? Here it is. Yeah, so the thing is, just like we have a oculostenotic reflex, there
Okay,
is
okay.
something known as oculothrombotic reflex also. Like as Dr. Pranav also inadvertently said, if I have a my thing is to routinely go with a thrombustor. But I was just trying to point out that you go with a thrombustor when there is a huge thrombus burden. Now, at the outset, meaning this is not my case, but I wouldn't have done anything different than what, if I suspect thrombus, then I would also go routinely and do it. And this oculothrombotic reflex is something like, in spite of the fact that it has been, thrombustor has been shown to be a class 3 guideline recommendation by all the guide, both the European as well as the American. The Japanese give it a class 2B, if at all, for high thrombotic burden. But yet, the usage of a thrombustor in Japan is said to be to the tune of more than 50% of all STEMI cases. Okay, in spite of all this, they do that. So here is the patient, a typical STEMI, and what do you think is the, this is my colleague Dr. Tilak Suvarna, whose case I just picked it up. What do you think is the duration of presentation for this patient? He's come really early. He's a youngish guy, 51, no real risk factors as such, and has come out of the blue, come to the ER and has been taken in by my colleague. And this is how it is. So there is a TIMI, virtually anything, but there is some flow down that artery, and there is obviously the thrombus that you can see there. But what do you think about, how would you go about this now? Wire, and then would you use a thrombustor at all or no thrombustor? Is my colleagues can, you can just ponder over and we can discuss this. Okay, so what has happened is, as is what we are wont to do, we've used a thrombustor in this case. And the next slide, 1 second. Wired it and just a thrombustor. Quick run on the thrombustor. In fact, some little collection was also, some little thing was also collected there. And you see the next shot. What do you think about this flow? This is a little better flow, but is
Better.
it related to the
Still stuff.
tautering of the artery, or you think the thrombus is cleared? I think it has cleared. So at this stage, what would you do? Just these questions. I'm putting up these questions so that we understand the sequence in which what would one do. So this is, you can't see any calcium anywhere. He's only 51-year-old. So now I'm just think about these questions. This is all, of course, retrospective. This has just come to me because there was a shortage, and Dr. Rishikesh told me that if you can bring out something, and my colleague was kind enough that you present this patient if you want to, and you present it the way you want it. I obviously know what has been done. So what has happened, as is what we are wont to do, a ballooning done. And after ballooning, what has happened? If at all this is worse now, and then what do we decide to do? We put in a thrombustor again, suck it out, and then what has happened? Because sorry, go back. Let me just go back. Yeah, so this is it. Let us play this. So thrombustor again, and then you see the angiography there itself. See what's happened. We're back to square one. So now what will you do? Back to square one. So obviously, stent works. The best thing to do for a thrombus or a STEMI scenario is to, you really don't know whether you caused a dissection with the balloon or what happened. And again, the balloon positioning, the first one at least that was shown, seemed a little more distal or whatever it be. So the next thing to do is to bring the stent in, because you already ballooned that artery. The compliance of the artery is not an issue. You've done a stenting, and then you've given, of course, the masala is on because of the fact that you can see the patient is more tachycardic. All the vasodilator business has been given. In fact, he's also received eptifibatide. And this is the final TIMI3 flow which you have achieved. My thing is about only the sequence of doing it. So let's now stop sharing. And I suppose you don't want to see it again, right? Neither Pranav wants to see it, nor Dr. Shastri wants to see this again. So now discussing this case, what do you think? Now, in the first instance itself, would you have ever put a thrombustor in there or no? That's the first question. Dr. Shastri, what do you think? We are all right to discuss it because it's somebody else's. I could have also done in that same order. Just discussing aloud what's the way to go about it.
Again, the question of IVUS comes into question, sir. Why not imaging first? If we had IVUS.
Why not? Yeah, of course, the budgeting and all that. And we are in a palmy scenario. Yes, this is again a good case to have, because you got a good flow down that artery.
Absolutely.
Putting in imaging is not just boom, one image and come back. You know exactly what to do. You know exactly, more importantly, this. Why not just direct stenting? I mean, there was one school of thought to begin with. What has worked in this patient is the stent in itself, right? So, basis the proximal artery, you decide, and the first angiogram itself shows like a 3.5 artery, if you ask me, really, isn't? I really don't know what stent size has been pushed eventually, but a direct stenting and then imaging also is still okay. But just to understand the reference diameter is, number one, we could have been directly stented it, but you don't know, with a thrombus sitting there, you might have gotten slow flow. So just ballooning with a small balloon, that's one way of going about it. Or in that thrombustor scenario, you got already a good flow there. Was there a need to balloon at all?
No.
Meaning after the thrombustor, the first run. This is again retrospective. If at all, so you really don't know the sequence in which to go. So how would you go now? Pranav, you tell me, how would you go about it?
That looks like a plaque rupture, sir, and more probably this is the lipid-rich plaque. So I would go with a direct stenting in this case.
Yeah, and here it looks like a good case at the end of it all. Just that direct stenting that would have done the job. And then, of course, after the direct stenting, you go in and see what is the reference so that you can give a good pot, etc. Because invariably in a direct stenting, you almost always undersize you never get the size of the artery. Everything is in spasm, so to say, and you do not get the thing. So this will keep on. Now, each one to himself, you leave it to the discretion of the way you go about doing an angioplasty. But the main goal is to achieve a TIMI3 flow. And now today, Pranav also alluded to the drug-eluting balloon thing. As of now, they're not approved in an ACS scenario. But yes, just a balloon. Good old days, we just did POBAs and came out, right? And when stents were not there, when we did POBAs, I'm talking about the Jamana when we learned, meaning the first of the stents, the Parma shots, we used to cut it into two and put it. If at all, it was meant only for a dissection in an artery, right? It was not meant for giving a restenosis benefit as such. And that's when the restenosis benefit comes with a POBA also, and you're happy to leave alone an artery alone without it. So if at all the great, by the way, those days I in fact wrote an editorial on a stent-like angioplasty versus BMS. No difference. There are enough number of articles on all this. I wrote for a newsletter I used to write. So there was no difference in a stent-like balloon angioplasty done versus the bare metal stent. Only place where stents started helping you out was abrupt closures, which could happen in a STEMI scenario again, may the undiagnosed dissection without this thing, or the thrombus itself there, which is there, and you may get a reocclusion also. You want to come out with a, that's what the emphasis in a STEMI scenario is. A TIMI-3 flow, try and avoid distal embolization, and of course, no bleeding. Now, this patient is, of course, on an eptifibatide in addition to everything else. You got a 24-hour eptifibatide going. So that's how it is. So thrombus continues to trouble all of us. That's the message I would give here, isn't it? Thrombus, dealing with thrombus is difficult. At times, do less. You talked about deferred way. So I purposely brought out that point. In your case, there, you saw that it was all choked with this thing. Would you have liked to come back again, given
24 to 48
that,
hours.
if in your own opinion, it was post 24 hours, more than 24 hours, so one can come back, and coming back also, we have had enough number of cases, especially if it is in a critical area, like a left main distal bifurcation and right at the ostium. If there was a problem, what would you do? For instance, in a thrombus sitting there, you want to do it on what kind of a scenario? Yeah, whether you can come back. We've come back in good old days with proximal LED, taken more time, and then we have come back, and then the artery actually looks better when you come back. So that's what it is. Anything more to add or subtract out of here? Imaging, I wish Jabir was there. Jabir is a big fan of imaging, isn't he? So he's like comes from Lizzie Hospital, where one of our Mumbai colleagues, my colleague Ronnie Matthew, is also over there, and they are very fond of imaging. And so much so, we had recently a debate and a good conference in Mumbai where I was giving the contrarian viewpoint, just for the sake of argument, that imaging, how good has it done in terms of preventing MACE? You have to look at meta-analysis results to try and say imaging works. But yes, it works to give definitely in, not if not in the long term, but in the acute scenario, to do complex lesions. And STEMIs in a complex scenario, like 75-year-old STEMIs, your STEMI, the first young one versus this one, though the young one got complicated and the old one allowed you to come out with a more successful result without shedding a few shedding more adrenaline, so to say, and getting aging you. The second one, the aged lady did not age you as much as the first one did. Yeah? So that is what it is. If you are playing with fire, you have to burn your fingers, and that's how it is. Great
Sir,
cases. I think if
with your
you have to add
permission,
something,
sir.
go ahead and add.
Yeah, sir, with your permission,
Sorry.
sir, I would, if the next chance happens, I have a case with imaging, with calcium, with everything, and still it got complicated. So I'll put it next time with your permission.
Yeah. So
And
that
that
is
was
what it
acute
is.
MI.
That
Acute
is
MI
what.
with
So
all.
therefore, we must appreciate Emcure's initiative, Dr. Rishikesh's initiative to bring in complexities of, though it is called no, as to whatever we experience in the cath lab. Case-based discussions really are interesting, and in the light of that, what is better or what is not, we learn from each other. And I do like to learn from the younger generation more than I do from my elderly people. Yeah. So the younger generation, I was alluding to Dr. Ronnie Matthews and Jabir. They are one of the very high volume imagers in the country. Yeah. So they wouldn't do anything without imaging, is how it is. And so also I believe Dr. Shastri is very fond of imaging. But yes, it makes your life easy. And so in a thrombus scenario, now having said that, there is something like a sonothrombolysis being worked on. Forget the sonothrombolysis aspect, but ultrasound energy to lyse the thrombus.
Still in the conference.
But ELKA, now example laser for resolving a thrombus. Again, my colleague from Mumbai, one you might know him also, Dr. Kirti swears by laser for thrombus. I'm not too sure, but yes, it is like using a horribly expensive device for dealing with thrombus. But it deserves it if it is going to come out as meaning you have dealt with I call it the villain of the piece, thrombus. Yeah. So if you can deal with thrombus, nothing like it. But if you go to look at it from an academic perspective, nothing has really worked for thrombus, and therefore the only large scale trials that have occurred as with mechanical, sorry, not mechanical, manual aspiration
Manual
catheters,
aspiration.
and those have failed. Those have failed. But large burden thrombus, as interventional cardiologists, I think, and I do use a lot of these thrombusters in a scenario where it's again dwell time very little inside the artery during a STEMI scenario with whatever devices you want to bring in. You want to be quick and out and get a TIMI3 flow. That's what you're aiming for. With or without a stent, with or without a jacket, whatever you do, you come out fast, get a TIMI3 flow, get the STs down and come back later. That's how it should be. Having said that, we discussed this issue also in one of the debates. Your patient, in addition, had a what do you call the left LAD also involved. And then when do you address the non-culprit artery? At the same time versus later? Now you are I understand, I know what the Derwent Hospital is all about. You do it at very low cost and there is a lot of funding that comes along. So it's fine. But otherwise, in our scenario, it becomes so valid that you do it pre-discharge so as to save on costs. Because at least my institute, even my private institute, now I'm not talking about my university hospital scenario, where we waive away the cost of the second angioplasty in terms of the operator costs, except for all the table charges. All that is charged for a second time when I come for the second non-culprit lesion before discharge. It's only the hardware cost. So then now it's a prudent decision not to intervene when you have had a problem and then come back, especially if you're thinking about also a cabbage option or another option. But otherwise, it adds to the cost. That's one of the main reasons why you want to do it at the same setting. So again, the jury is out about when to address a non-culprit lesion, whether at the same setting, immediately at the time of the STEMI intervention, after a TIMI3 flow in the culprit artery, or during index hospitalization, or within the first 45 days, as was based on the complete trial done by we know them very well, Shamir Mehta and the group. My colleague is trained with him, and I know Shamir Mehta personally from Hamilton. So they are now coming up with an entity called as a trial called as Complete 2. And in the Complete 2 trial, a very mega trial, they are going to have imaging to look at the non-culprit artery and decide even the vulnerability of the plaque there, so as to be using OCT as well, so as to decide whether you address it at that time or you address it later, and how it's going to pan out. Only time will tell, because vulnerability of the plaque wise, the PREVENT trial, at least using all this imaging technology, vulnerable plaques, if addressed early, though there is not a mortality benefit, but the primary endpoint wise, it was a successful trial, the PREVENT trial, wherein non-flow limiting but vulnerable plaques were addressed, and it was shown to benefit, right? Yeah, in terms of the primary endpoint, that is recurrent MIs and all that were low, recurrent revascularization was low. So in that case, if you both don't have anything to add, I think we should come to the end of the conference. And thank you again, Dr. Pranav. Excellent. Thank you, Dr. Shastri.
Thank you, sir. It was wonderful. Cases were beautiful, sir. Really, really very interesting cases. Thought-provoking.
Very good cases. I just decided to show mine just to pose questions as to your thinking process, because we had a case. Again, I'm good to discuss it because I have my colleague's case with me and he's been nice enough to give it. He's achieved a great result at the end of it all. But what Thrombuster can do, you want to chase it with something. Sometimes that nothing works better than a stent. And then sometimes we defer a stent also, isn't it? So it's
Yes.
the experience that matters also, and what you do at the end of it all. Thank you so much. Pleasure being with you all.
Thank you. I
Thank
would
you,
like
sir.
to express my sincere gratitude to our respected course director, Professor Praful Kerkar sir, for sharing your knowledge and expertise with us today. Thank you, sir, for appreciating the Emcure initiative of no thrombosis, and I'm pleased to share with all that we have completed 4 years running this program successfully. And Professor Praful Kerkar sir, your guidance is helping us to run this successfully, and thanks for bringing lot and that has really helped the audience. Many interventional cardiologists across India regularly are the delegates for this program. I would also like to thank Dr. Rajnikant Shastri sir for sharing his knowledge and expertise with us today. I would also like to thank Dr. Pranav Shamraj sir for the insightful case presentations. Thank you for presenting 2 cases. So this compensated the absence of another speaker who couldn't join due to some emergency. Your contribution has definitely, undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their continued love and support and time for the No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everybody from sales, marketing, and medical team at Emcure who have contributed to this program success. Thank you all once again for attending and encouraging us. Good night.